I think it's a conception that the glasses are part of what you do to make me feel better almost immediately. This is a medical solution. The training and the aura of supplements, rightfully so, there are a lot of bad supplements out there, have that tendency to bring a physician to say, well, I don't really know. I'm not versed in that science. I didn't learn that in school. There's got 29 optometry school, and we won't get into the board results that you and I talked about in Houston. That don't really teach supplementation for vision.
Hello and welcome to the Chris Wolfe Podcast on iCode Media. Today, I'm going to have a conversation with Frederic Jouhet. I know I'm going to butcher that name, Frederic, but
close enough.
The fun part about today's conversation is that the information that Frederic and I are going to share with everybody today shows me a couple things. First is, on a couple of weeks ago, I discussed utilization data for visual fields within optometry. But that same very week that I was developing that for the podcast and for some other continuing education lectures, Frederic and I sat down and discussed his calculator related to specifically macular conditions and also floaters and also supplemental conditions that are amenable to supplements, and how we can use prevalence data to understand what we should be expecting in our practice. And I think the really cool part for me was to understand that, yes, I think about this as a consultant or as an eye doctor, but there's other people outside of our profession that look at this data and question what it is that they see in the data. And so I wanted to have Frederic on today. Frederic's with MacuHealth. MacuHealth's been a big supporter of the podcast as well, both for Aaron and myself. So thanks, Frederic, for that. But I wanted to have you on today, Frederic, to talk about what you see within this data. So as always, be sure to subscribe to the podcast, write a review, share it with your friends, and support those who support us. As you know, patients with vitreous floaters are often frustrated by their symptoms. The challenge as clinicians is to offer solutions for our patients for vitreous floaters that are effective. But more often than not, the options of YAG vitreolysis and vitrectomy are not practical because the benefits don't outweigh the risks. That's where Vitreous Health from MacuHealth comes into play. Previously on the podcast, I've discussed the FLIES study with Dr. John Nolan, and the bottom line is that I can be confident prescribing this for my patients with floaters because I can tell them a large randomized placebo-controlled trial found that after 6 months of supplementation with Vitreous Health, floaters were reduced in size by approximately 30%, and 70% of patients had an improvement in their symptoms. Vitreous Health has been great for my patients, and we really feel like we have a viable option to treat patients with vitreous floaters now that we didn't have before. If you're not utilizing Vitreous Health for your patients, reach out to your MacuHealth representative now. I want to discuss the MyDay toric contact lens for a minute. When I'm reaching for a daily lens for my patients, I need to know that it will be available in the parameters I want, and it also needs to work. This improves my chair time and my patient satisfaction. The MyDay toric lens features the same optical lens design features as the most prescribed monthly replacement toric lens on the market, the Biofinity toric. MyDay toric now completely mirrors Biofinity toric's parameter range, and to be clear, this means that if you can find a parameter in the Biofinity toric, you can find it in the MyDay toric. This toric lens design is multifaceted to ensure optimal visual acuity, lens stability, fit, and comfort. Its uniform horizontal ISO thickness and wide ballast band quickly orient the lens for better performance and simplified fitting processes. When prescribing MyDay contact lenses, you can feel confident about your environmental impact because for every MyDay contact lens sold in the United States, CooperVision's partner, Plastic Bank, collects and converts an equal amount of ocean-bound plastic through their global network. The MyDay multifocal and MyDay toric contact lenses will provide your patients with great vision quality and comfortable lens experience, all while making a difference in our environment. So if you haven't started utilizing MyDay multifocal in your practice, I'd encourage you to reach out to your CooperVision representative to get started. So, Frederic, you and I had this conversation, but let's take this back a little bit before we actually get into the calculator. what were you seeing and what were you kind of curious about that made you say, let's figure this out? What are the metrics that we could use that would be helpful for a doctor to understand the impact on a practice?
I think the first thing that I always tell my team is, in order to be successful, you need to know your environment. And we always assume that professionals in their own environment have a very complete and thorough knowledge of the space they evolved in. At the last sales meeting for Matthew Health, I showed them a cartoon where you have those two little monkfish swimming, and there's a big fish coming to them and looks at them and says, "Hey boys, how's the water?" And they just walk away or swim away. And about a minute later, one of the little fish looks at the other guy and goes, "What is water?" And I realized that's kind of what we're looking at the optometry level, is that if you really boil down and drill down with a lot of your colleagues, most of them are still doing refraction and lenses, which is a scary proposition.
Well, it is. And I think, so where did you see that? So I see that all over the place, and I see that in data that I analyze, and I wonder, am I just biased? Do I have this preconceived bias where when I think what you're saying, and I do think that in a lot of cases, we have all this knowledge, education, and training, but where the rubber meets the road and the value that we drive from, where we generate revenue, is prescribing glasses and contacts. So I see this in data. Where did you see it?
So I come from not even the outside. I come from a different planet than optometry. I'm not a scientist. I am not a doctor. I'm a lawyer. I'm a legally trained person. I never practiced law, and a businessman. So when we first started Matthew Health, I used to go and talk to, I don't know if mute this. I used to go and talk to doctors, and doctors' objections would be very interesting to me. It would be, well, I don't sell things. Okay, so I actually did this once. I want to move a little bit this way. I actually did this once. I said, "Oh, that's great. You don't sell things." And I just started to grab a whole bunch of sunglasses of very high level brands and stuff them in my pockets. And a doctor looked at me and goes, "What are you doing with those?" I said, "Well, those are free. You don't sell anything." And he goes, "Oh no, we sell those." I said, "So we do sell things." And I think what I discovered very quickly, and it's not centered or it's not exclusive to optometry. Everybody has a natural tendency to stay in their comfort zone. So every time something new comes up, there is a pushback, because that new thing, no matter what it is, and I had conversation with you, I had conversation with Harvey Hanlon and a lot of doctors. Optometrists thought that OCT was the end of optometry. Now, speaking to Keith and on my team, I was shocked to hear that 30 years ago, I would not have been able to buy a pair of sunglasses at an optometry practice. So I started to dive a little deeper into the numbers. And obviously, we know nutritional supplements have increased in size and markets by leaps and bounds for decades. There are actually more non-pharmaceutical products sold than there are pharmaceutical products sold today. But a very small portion of that is sold at the practice level, because they think about it as I'm selling something. Where really you're prescribing something. And that's a change of mentality. So in order to figure it out, I needed to drill down to the numbers.
What did you find that was what's in the provider's mind, what was the difference between the prescription for the glasses that they would write and sell versus the prescription for the supplement that they would write and then sell? What was the dividing line that was the mental block, or that is the mental block that still exists in many of us, to distinguish those two things?
I think it's a conception that the glasses are part of what you do to make me feel better almost immediately. This is a medical solution. the training and the aura of supplements, rightfully so, there are a lot of bad supplements out there, have that tendency to bring a physician to say, well, I don't really know. I'm not versed in that science. I didn't learn that in school. There are 29 optometry school, and we won't get into the board results that you and I talked about in Houston. That don't really teach supplementation for vision. So if you do not have that training, if you feel I don't want to really learn what's there, you very easily default to say, well, why don't you go to the pharmacy? But now another piece of information falls in is the science has established that about 70% of the product in my space don't have inside the box what they tell you they have in the box. There's no regulation.
Yeah.
So would you send your patient to go get readers like I have to a pharmacy because you know that the readers that are there are not the quality of the one you're going to be able to manufacture with the lab? So there is really there are three things that need to be addressed. The education part, that's our job. The need part, it's also our job. That's kind of what a calculator is. And on the doctor side, they need to realize that the population is getting older. We're spending more time than ever on screens. Our eyes are damaged by all that. What are you going to do with this? Or are you going to wait for somebody to be blind and come back and say, well, there's science that shows that supplementation could have been helpful, but when I look at my patient file, there is nothing about recommending supplements. And that's the stick, which is a problem because eventually law firms have already started to look at, well, you're not doing your job, doc. Yeah. So that's how we started digging into numbers. And that's how we ended up with all that data that created the calculator you mentioned.
Well, I want to share that too, because so I think that's a great setup for where we start and actually look at this. Because, the first thing that I love about this calculator, and immediately spoke to me when you showed this to me this last week or a couple weeks ago now, is you started by saying, this is not me. This is not Frederic from MacuHealth coming up with these numbers. We're citing data from the CDC and the Vision Council and the National Institute of Health about what to expect. And so that's one thing I want to take just a second, Frederic, because that is important, and it's not something that I think most doctors are walking in with a patient for a comprehensive exam thinking I should expect in a patient that's this old, thinking I should expect 20% of them to have this problem and 30% of them to have that problem. We learn it. We memorize it in school. We regurgitate it for a board examination if we can, as you discussed, if we can pass that board examination. But we don't bring that into the exam room generally in a patient who has minimal signs or symptoms, or they don't know how to tell us about those signs and symptoms when we walk into the exam room, and they don't know that we can fix or help them with those signs and symptoms. So understanding that that if I expect this percentage of patients to have this problem, and I don't actually see that in my patient population, it's a me problem. Like, it means that I didn't ask the right questions or I didn't find the right things through my examination. And actually taking that path when you walk in. Now, that doesn't mean you have to think about like, okay, well, there's a 0.00 risk of that patient having, multiple sclerosis and acute optic neuritis. Like, you don't have to get to that granular of a level. You can just say like, all right, a patient over the age of 40, there's 6 things that I can't miss, right? And I want to find any of those 6 things. So I'm going to cast a wide net on those 6 things. And so my point there is, Frederic, is that speaks to me, and it speaks to sort of my message when I talk to groups of doctors, either on the podcast or in person, of saying, hey, let's think about what's in a comprehensive exam. We have a really wide net to cast. Let's not miss the stuff that we can do things about and help patients with. And part of that is having perspective on what should I expect when I walk into the exam room. And so that's where we start here. And I'll kind of set that up and let you take it away from there.
So we did research. What we did is we're trying to figure, is there data out there that can allow us to segment the population? And really, what it came from is somewhat my own eye exam with a doctor that great guy, fantastic doctor. And I was laughing in the chair, and he looks at me and goes, "Why are you laughing?" I said, "You never asked me anything past taking the eye acuity, the visual acuity test." He goes, "What do you mean?" I said, "You didn't ask me if I had problem with glare, if I had problem driving, if I had blurry vision." "No, I asked you." I said, "No, you asked me how you doing. That's a little too general for me to answer all those questions. And you had time to ask those questions while you were doing the exam in the room, or you didn't." So that is not done. The visual acuity test, I always laughed with Lloyd when he took my exam. Said, I learned the chart by heart in the Navy, because if you didn't pass 2015, you didn't go. So that's a problem. I think contrast sensitivity is a much better way to do things than just acuity. But going back to the data, we found data at the CDC, we found data at the NIH. It says NH, but it should be NIH, at the Vision Council. And then we regrouped that data to figure out what percentage of the population has what. So when you look at medical conditions, the red obviously is what you would call the diseased eye, and the blue is what I would call more a healthy eye with issues. So I presented that, and I was asked, the first question is, what amount of patients, what's the average number of exam and patients you're going to see in a year? And I put 2,000 in there. I told you to, I asked you that question in Houston, and you said the same thing. It's going to be 2,000 to 25 on average. Mm-hmm. So by populating that number, now we find ourselves with actual data of what is in the practice. And if we go from worse to better, for lack of a better word, the 0.94% of vision threatening, we're looking at people who are very likely already gone from the optometry practice and at a retina specialist getting injections. So to me, as the non-OD in the room, I look at that and said, that's a liability out there. Because I have 19 patients that I've seen maybe for 10, 15, 20 years, and on my watch are now getting injection. Doesn't mean that it would happen if you had used supplementation. It could happen, but you have nothing in the client's file to say, I have addressed or I have spoken to the patient about that. And you have 18% that have been diagnosed with AMD. It could be from having lost a line of vision to just have very intense drusen of a certain size. And we know that 15% are at risk. And what's very funny is, we'll get that in a minute when we go to the practice. And when I presented that to the Florida Optometry Association in a room, I said, okay, well, how many of those 19 patients are you going to convert and put on supplementation if they are getting injection? And there's a loud roar in the room, 100%. Ask boss, I don't believe you, so I'm going to put 10%. And we go down the line. So diagnosed 10%, at risk 10%. So dry eye, fish oil, obviously high quality fish oil has been very good for dry eye. Dry eye is 27.2% of the population. Something that we are the only one in the game right now with floaters. I was shocked to see that about 76% of people suffer from floaters. It was actually explained by a friend, optometrist, that if you're in your 20s, it's about 20%. And every time you add a decade, it is another 10 point. And if you have other conditions, such as diabetes, it can go through the roof. Then you have blurred vision. So blurred vision is a low macular pigment, as we know, and you pass the visual acuity test with flying colors, but you can see if the street coming is Main Street or First Street because it's too blurry. Eye strain, that was one condition that I didn't think about, is a 32.4. Night vision, massive problem. And doctors will think, well, it's only the elderly population. I can't tell you the name. I would just say this: the lowest macular pigment, my chief scientific officer, Jim Stringham, has measured, is a starting quarterback in the NFL. And when he talked to the kid actually said, well, I really don't like to drive at night. And I think Jim answered, you're not supposed to say that for another 40 years. But he had a 22-year-old kid who had a problem with glare and night vision. And then you have sports performance. So if you just do 10% if you convert 10% of these patients.
Do you think it's fair? I could add 10% for blurred vision, eye strain, night vision, for sports performance?
I would put zero right now. For what practices are doing, I would put zero in those.
Okay. So you're putting
and I would tell you at 10%, we're generous on the other categories.
Look, Frederic, I think you're right. I am one of those. I mean, we use a lot of your supplements for this for the first three, for sure. And then for dry and floaters, we use some, but a little bit less. So I think we do a better job than the 10% in our practice, but I'm totally ignoring the other stuff that you're bringing up here: the night vision, the eye strain, the blurred vision. I'm guilty as charged, right? So that's what was helpful for me.
And before we drop down further, that's the one thing as a business guy that drives me insane. So you have the largest drain on Medicare Part B is anti-VEGF injections.
Oh, yeah.
Okay. So the more Medicare Part B goes up in volume because we don't do anything, the more Medicare Part B requires money. It means that we have to take it from the other side because it's a scale. So that's the reason why an OCT exam is reimbursed at what now?
$37.
What was it when it started?
Oh, it was probably 90, pretty close to that.
So
yeah, maybe more.
That job, yeah, I think it was over 100. Yeah. Not doing supplementation to alleviate issues will increase the size of those issues. We're going to end up providing a strain on Medicare Part B that is going to be offset by less revenues on A, which is back to the optometry office.
Yeah.
So now if you scroll down, if we do 10% on diagnose on vision threatening, so the first 5 categories, we're looking at $93,000 of revenues, gross revenue.
So what you're saying, to put a bow on that, you're saying if I just did 10% of the first 5 in my practice and identified those correctly based on what I would expect, then it's an incremental revenue of $92,000.
Yes, absolutely.
Yeah.
And I think
that we're giving away.
That you're giving away to a pharmacy and you're putting the patient at risk because you have no idea which one they're going to buy. And I'll tell you my habit: if you send me to the pharmacy to buy something, I'm going to buy the cheapest.
You find the cheapest. Yep, that's right.
I mean, look how exponentially it goes up.
Staggering.
That's staggering.
Yeah, that's staggering. So just for the listeners, if we just put 50% of, patients who have vision threatening macular degeneration, or 50% of our patients in a 2,000 patient population with diagnosed AMD, 50% of those at risk for AMD, 50% of those patients who have dry eye on a supplement, and 50% of those patients who complain of floaters on a supplement. If you look at that metric, it's about $460,000 of incremental revenue to a practice of seeing 2,000 patients a year. So pretty staggering. Frederic, is anybody doing this level? When you look at your MacuHealth users, are there offices that 2,000 patient population that are generating that kind of revenue?
Yes, I mean one of the one that who has sold the practice since, I won't mention his name, one location in Maryland, sold to a private equity group as his retirement. And I believe he was at $500,000 of gross revenue. Jeez. So if you just do the math, and I don't want to speculate, but it's about a 50% net to the doctor. So it's 250. If you got a 7 or an 8 multiple at that time, that's about $2 million of the buyout of your practice that came out from supplements. Wow. Doing the right thing.
So tell me what. So I want to be respectful of your time. I'm kind of interested, and maybe for the listeners, maybe as a patient, if you're sitting in the exam chair, and also as a business owner, you've heard a lot of doctors talk about these things. So I want to pick one that's not so easy. I think the AMD is very straightforward in my practice. I can explain that really well. Floaters are not hard for me in the sense of patients who have those symptoms, discussing it with them. But I'm not as good. What about, like, how do you want it to sound? Let's say you've had floaters, you've had a PVD, or you've had floaters for years, and you're in my office and you say, "Oh, doc, I have those floaters for a long time." What does it sound like to you if Chris Wolfe tells you a compelling story about what we can do now for your floaters and what's going to make you act?
So that's the one thing that I think should be taught in optometry school. In medical school, a lot of medical doctors, a lot of other profession don't have that. I don't know if it's a insecurity or sense of feeling of inferiority. If I am in your chair and I have issues with floaters, I have dry eye, I have a hard time driving at night, I'm going to you as the medical expert to tell me what to do. Okay, 2018, silly accident, jump over a dog in a house, land awkwardly, break my left fibula. When I'm at my buddy, the orthopedic surgeon, to put me back together, and he looks at me and he goes, "There are two options. We can set it, put you in a cast for 3 months, or we can put pins and plates in there and you'd be out in a month and a half." There was never a third option, or you can go to CVS and get an ACE bandage.
Yeah.
The patient wants to hear a solution. Then it's up to the patient to decide if they want to pay for it or if they want to do it. But floaters are, unfortunate I don't have them, but I've been told are very debilitating. So you have somebody who has a massive visual performance issue, who is looking at you, the professional, his or her eye doctor, and I have a problem. Well, there are 3 options. We can do a laser, that's a surgery. The other is the surgery itself, or there is this product. There's some good result on an early study. There's more studies coming, and this is the cost, and I think it's going to make a difference. Let's come back in 6 months and see what it did.
So I love what you've done there. I might even simplify it a little bit more, because first of all, in Omaha, the laser procedure, we just don't have anybody doing it. Like, we've got retinal surgeons, they just don't don't want to do it. And they won't do vitrectomies for floaters unless the patient is begging and pleading. And so I like the fact that you gave those 2 options. That's something I haven't really thought about doing. But then I think as I'm listening to you, I got to simplify it just like I would simplify with my macular degeneration patients is, these floaters, we have 3 options to treat. We have a laser procedure that's about 50-50 effective. We have vitrectomy, which the vast majority of retinal surgeons in the country aren't going to do a vitrectomy for floaters, and it's a high risk surgery that's going to lead to cataract surgery. And or we have a supplement that studies show will reduce your floaters by 70%. I mean, and we'll start you on that now. I mean, I think that helps
you just said
clarify
something very important. When you say, well, we have supplement, and then you said, we will start you on that. And that's, I think, where the biggest mistake is made in optometry.
Yeah.
If I'm the patient, you give me a choice, I'm going to take the least difficult one. If you tell me, there's this, not a big fan, this, nobody's going to do it, this is what I want you to do. I'm going to put you on that you're going to get 2 bottles. It's 6 months. I want to see you in 6 months, and I want you to tell me what it is.
Well, that's the other thing I like in your process that a lot of us mistake, and I actually would mistake as well, is that many of us would be like, okay, well, we'll see you next year. But you're saying, which I agree, you've got a symptom, a complaint from a patient. They have a medical diagnosis, vitreous degeneration, and there's nothing wrong with having an intervention, a treatment like you've talked about, a supplement, and we're going to follow up. And it's not like, if it's not better, we'll see you in 6 months. It's like, and I'm going to see you in 6 months to see how things are.
Let's forget we're talking about supplements.
Sure.
I do the visual acuity test.
Yeah.
I do the visual acuity test. I can only see the first 2 lines on top. Are you going to tell me, well, you can go like this squinting, or we can get glasses? It's up to you. No, you're going to tell me this is what you're getting. This is where, go find a frame you like. Do you want contacts? It's never an option. I'm not leaving this place without some type of correction for my eyes, for my vision. So why are we not doing the same thing and carry it on to a medical problem? Because really, the part of visual acuity, refraction, lenses is on your phone. It's becoming a commodity. I'm not a big fan of the words medical optometry, because I'm a big fan of optometry, and I would never say that they're not. You're a doctor. You're a medical doctor.
Yeah.
So, but it's the medical aspect of the practice that is missed and needs to be adopted and expanded. And if you look at the numbers we were looking at, what is the number one complaint that we get from optometrists when we are at a watering hole at an Expo West or at another show? I can't keep staff.
Yeah.
Well, let them participate in there. If I go there and I need contacts, Chris, you're not going to come out of the exam room and show me how to take him out of the box, how to put him in my eyes, how to take him out of my eyes. You have an expert there on your staff that does that. Do the same thing there. Now, how you compensate for that is entirely up to your system. It can be a spiff by bottle. It can be a bonus depending on how much you make at the end of the year. But now you have brought that staff, that good staff member, within the system of prescribing supplementation and getting revenues from it. And then you have increased that person's income, which makes it very difficult to find something more rewarding and remunerating better at the competition or across the street. Now you have stability of staff. You have to run that as a medical practice and a business. And I think a lot of that needs to be taught.
The most common questions I get include, what ophthalmological codes or evaluation and management codes should I use? What ICD-10 codes do I need to bill with this CPT code? What CPT codes can be billed together and what can't? And my favorite, how do I manage a patient who has diabetes who comes in for a quote-unquote routine eye exam? These questions really highlight the confusion and uncertainty that serves as a daunting hurdle for providers, makes it more challenging for them to care for their patients and provide those patients with the best opportunity for a lifetime of ocular health and clear vision. That's why we built iCode Education, for this specific purpose. Our mission is to provide optometrists with resources to help you understand disease states, revenue cycles, and billing and coding so that you can put that on autopilot and truly care for your patients. Check out eyecodeeducation.com. That's EYECODE education.com. We've developed a premier billing and coding bundle that includes all of our billing and coding resources in one place. We also have a 10% discount code just for listeners of this podcast. Enter the coupon code EYECODEMEDIA22 at checkout. We'd love to work with you. Check out eyecodeeducation.com. One of the challenging things with patients is that when they invest in a really high quality pair of glasses and customized lenses, occasionally it can be difficult to keep those lenses clean, scratch-free, and smudge-free. Now, we have the ability with Crizal Sapphire HR lenses to offer our patients a best-in-class anti-reflective coating that is also resistant to scratches, smudges, and deposits. This means that patients spend more time enjoying clear and comfortable vision and less time caring for their lenses. So remember that you can provide patients with the best in quality, best in class, transparency, clarity, durability, and UV protection in a single Crizal coating. If you want to learn more about Crizal Sapphire HR, contact your Essilor account executive or visit essilorpro.com/Crizal. Yeah. So I think, I mean, Frederic, I want to be respectful of your time. I think that kind of is, it wraps all of this up. No, I think this wraps all of that up in how somebody else would think about our business as a patient and as a business owner that would say, what do I want to hear from a doctor? And you're telling me, you're saying, you should see that patient back in 6 months. And I'll tell you, I say this all the time. In fact, I'm going to be in New Mexico this week, or I guess when this is released, I will have been in New Mexico last week. And the vast majority of what I'm going to be talking about is ocular disease management. What do our guidelines say? And how do you assign value to that ocular disease management? And there's such a big miss. And you know, you can listen to the excuses. You know, I was in when we were in Houston, the excuses are, well, you know, I don't have the staff, like you said, I don't have the staff to run the visual field, or I don't have the staff to run the OCT. So I don't run it as often as I otherwise would like to. And I'm like, to your point of legal issues, I'm saying, do our clinical practice guidelines say you run a field every year for a glaucoma patient if you have the staff to do it? Or does it say you run a visual field for every year for at least for a glaucoma? Yeah. It doesn't say if you have the staff to do it. Well, yeah, but you know, it takes a little longer. Patients don't like it. Does it say patients don't like it? It takes a little bit longer. So run it if you can, or if you like, no, it doesn't say that. It says you should run them every year or more if you need to. Right. But we empathize. I think the good thing about our profession, so you know this, Frederic, is the good thing about optometry is we care a lot about our patients. We care about a lot, and we care about a lot about how our patients perceive us. And we want to be a nice guy. I mean, we really do. Like, we want to have good relationships with patients because we're in the trenches with them in their communities. So they have to see us every day. They see us at mass. They see us in school. We are reachable. We're approachable. But we have to make sure that we're not letting that the concern about cost, et cetera, prohibit us from doing what is the best thing for the patient. And some of that is just we got to get out of our way.
I always said that when I'm blind and you never give me, or I have massive vision loss and you never spoke to me, you never recommended, you never said anything about supplement, what are you going to tell me? Sorry, I was trying to save you money. Because I'm going to look at you and say, I was coming to you not to go blind. Let me manage my wallet. Because I can always, as a patient, tell you, Chris, I can't afford it. Which puts the ball back on your side. Well, if you really think that I need it, maybe you say, okay, listen, to start, I'm going to give you this one for free, and this one is full price. So now you got a 50% discount on the supplement that you're buying. But at least you did something. And when that person starts to feel better, and if it's a good supplement, they will realize, okay, that's much more important than that $5 12 pumps of diabetes in a cup at Starbucks that I take every day. That's costing me $6. Because this is how you have to. This is how I talk to patients who say, "Well, it's expensive." I just look at them and stare, because it's not a question; it's a statement. I'm not going to answer the statement. So then they say, "Well, don't you think?" I said, "No, I don't think so." There are 90 pills in the box and match you up. It is a 90-day supply. So it's less, it's about 86 cents a day. Go get me a cup of coffee at Starbucks for 86 cents.
Yeah. It'd be that big?
Yeah, that's the same person who will go there and buy a $7 drink and
Every day.
very likely do it 2 or 3 times a day.
Yeah.
So you're spending
and they're waiting in
$21.
line for 20 minutes to do it.
So that's where the perspective is, because and I think that you're absolutely right about optometry and who you are and how much you care. I think the one thing I tell optometrists all the time, your patients see you as the expert. They know you're a good person. They know you're part of the fabric of the community, but they still go see you as the expert. Growing up in France, my uncle was a doctor. He was a country doctor. People will come to the house and say, "Hey, what do you think? You need stitches. Let's go in the back." I mean, they would come to him because that was the guy who had the knowledge to solve the problem. That's who you are, collectively and individually.
Frederic, I don't see a better way to end it than that. Thanks for being on. I appreciate it.
Thanks, Matt, for having me. Yeah. All right. We'll see you soon.